Okay, we start the gynecology section now, and these cases are going to be more single scenario and then not the multiple ones that we had on OB. OB lends itself a little bit more to that. This case is a 55-year-old with malodorous vaginal discharge. And I would suggest to you that on the exam, particularly in gynecology, the age of the patient is going to make a major difference in the kinds of things that you look for and what your expectations are. And basically, we're looking at prior to the reproductive years, during the reproductive years, or after the reproductive years. Because hormonal status is going to vary, and that's going to make a big difference. So, malodorous vaginal discharge. Vaginal discharge is the most common complaint that women bring to the primary, gynecologic complaint that women bring to the primary care physician. So this is a very common complaint. We have a 55-year-old woman comes to the outpatient clinic with 3 days of gray malodorous vaginal discharge. What I'd like you to do is to think of key words. When you see key words, it should make you think of a certain differential. Malodorous should make you think of what kind of etiology? Bacterial vaginosis. Past surgical history includes hysterectomy for fibroids 10 years ago. Who cares? There's a lot of extraneous information. She's on estrogen hormone replacement therapy. That may be important. She's afebrile, vital signs stable. Pelvic exam reveals a gray, fish-like, smelly vaginal discharge. What does fish-like smell make you think of? Anaerobes. Anaerobes, and in fact, that's what we've got here, probably. No vulvar, vaginal, or cervical inflammation or lesions. So our differential diagnosis will put down the whole raft of them. Bacterial vaginosis, Candida vaginitis, Trichomonas vaginitis. I'd like you to pay attention to the last 3 letters here, or 4 letters. This is osis, bacterial vaginosis. Candida is an itis, and Trichomonas is an itis. Why isn't it bacterial vaginitis? There's not an inflammatory reaction. And that's going to be very helpful when we look at our diagnostic criteria. Gonorrhea, chlamydia. Okay. Our initial diagnostic plan. This is one area which is often overlooked, is vaginal pH. And you'll see how helpful that will be. Then we'll take some of the fluid, vaginal fluid, and we'll put it in a hanging drop preparation. We'll take a drop, put it in saline, put another drop, KOH prep, and then put a cover glass over that and look to see under the microscope. The whiff test. The whiff test is where you take the speculum and you go. You see, you've got to use all of your senses. Now, how did you historically diagnose diabetes? Tastes sweet, right? I remember when I was on the internal medicine rotation and I was on the GI service. And before making rounds, or maybe it was after making rounds, we'd go into this special room where they were paint cans. And they had the lid tightly sealed on it. And what do you suspect was in those paint cans? Stool. 72-hour stool collections. And I remember the professor would take his screwdriver that he carried around in his pocket, and he'd break open the lid, he'd go, lactose intolerance. Take out another one. He'd make the diagnosis just by sniffing. See? Well, this is kind of like that. The pH is 6. What's the normal vaginal pH? Less than 4.5. pH is elevated. That's going to be important. The hanging drop shows clue cells. Let's look at what clue cells look like. No white cells, no yeast, no trichomonads. No white cells means there's no inflammatory response. Whiff test, positive. Okay, our diagnosis, probably bacterial vaginosis. Now, I'd like to propose that we give a different term. Instead of bacterial vaginosis, we'll call it vaginal bacteriosis, because it isn't a problem with the vagina. It's a problem with the bacteria which are in the vagina. And I'll show you what happens with that. This is the normal vaginal flora. What's the predominant organism? Lactobacillus. Lactobacillus is your friend. Lactobacillus takes the glycogen, which is in the epithelium, takes that glucose, converts it into lactic acid. Lactic acid lowers the pH and keeps all of the anaerobes and other facultative aerobes under control. And the primary one is lactobacillus. And then we've got, after the BV, bacterial vaginosis, the other species take over. Now, we used to think this was called Gardnerella. You remember that? Gardnerella was just a marker organism that increased along with the anaerobes. You don't treat the Gardnerella. What do? How do you treat the anaerobes? Metronidazole. 500 milligrams orally, BID for 7 days. Now, you could use local treatment as well, but this is pretty straightforward. No need to treat the sexual partner because this is not a sexually transmitted disease. Here you got the clue cells. This is a normal epithelial cell. Notice the clear border. The cell borders are clear. What's all this stuff around the edge? Anaerobes. So they're adhering to there. This is the treatment. Once a day, Metrogel. Simply cures BV. Now, what is this? What's the ladybug have to do with bacterial vaginosis? I have no idea. This is the advertisement that the drug company sends out for Metrogel. All right. Any questions on BV? Pretty straightforward. pH is going to be elevated. You're not going to see any evidence or minimal evidence of inflammatory response. No white cells, no erythema, no swelling, no pain. And on the wet mount, the saline, you will see clue cells.
Small question. Most monoculture women are not prone to STDs. This is 55-year-old person.
Yeah, this is not an STD. This is not an STD. Question? Pregnant lady with bacterial vaginosis. Third trimester? First trimester? It's a theoretical concern regarding the fetus. There really is no significant impact of this. If you want to wait till after the first trimester, I would use it in the first trimester. What is safe? What is safe? Are any drugs safe in pregnancy? Class A. What are the safe drugs? Synthroid, acetaminophen, and that's basically it. So it's a relative ratio of risk versus benefit. I wouldn't hesitate to use it. Okay, 39-year-old with vaginal itching and soreness. Now this is different, see? Before we just had the smell. This is now itching and soreness. 39-year-old woman comes to the outpatient clinic with a 3-day history of vaginal itching that has become embarrassing and unbearable. Her vagina has become red and sore. Now we have not an osis, we have an itis. Itis. So our differential diagnosis here is going to be a little bit narrower. Her last period was 10 days ago, normal in length and consistency. Denies any underlying disease except she had a UTI a week ago treated with ampicillin, broad-spectrum antibiotic. A febrile, stable vital signs, mild vulvar erythema. Speculum exam reveals vaginal erythema and edema along with whitish discharge. No cervical motion or adnexal tenderness. There you got it. What does that look like to you? Looks like candidiasis, right? That would be our number 1 on the differential. Bacterial vaginosis, unlikely. Trichomoniasis, yeah, probably, possibly. Cystitis, no. I think it's probably candida. What are we going to do? urinalysis just to make sure there isn't a cystitis, because you did have a UTI diagnosed. Vaginal fluid pH, hanging drop, saline, and KOH. What did we find? Urinalysis, negative. Vaginal pH, what should it be with Candida? Normal. It is normal. And the hanging drop, saline, KOH, pseudohyphae, white blood cells. No clue cells, no trichomoniasis. This is going to be a yeast infection. Now, if you look under the KOH, this is what you're going to see. Once you see that on the exam, you've got the diagnosis. What you see in the background here is the organic debris which is being dissolved by the potassium hydroxide. Assessment, yeast vaginitis, probably secondary to the broad-spectrum antibiotics that were used, and the treatment can be either topical or it can be oral. The topical, there's all kinds of different azole creams, miconazole, triconazole, butaconazole. Every company thinks that theirs is the best. And this has to be used over a few days, whereas you can use an oral agent, which is a single dose of oral fluconazole. And that has a high compliance, which is one of the benefits of that one. So here we've got monostat, which is miconazole inside and outside. How's that? Here is gynazole. That's a good name. Butaconazole, one dose anytime. And here's your fluconazole. Hate the yeast, love the treatment. Can you believe this? This is what the advertising people send out to the doctors. Hate the yeast, love the treatment. Any questions on a yeast vaginitis? Get a vaginal pH. It's going to be normal. Now, how about with trichomoniasis? What will you see? pH is going to be elevated. What will the discharge look like? Green and frothy. On the exam of the vagina, it's going to be redness. It's going to have the tumor, rubor, dolor, all of those things. And you're going to see the trichomoniasis, the trichomonads swimming around in the saline. Treatment for trichomoniasis is going to be your metronidazole, and this is a sexually transmitted disease. Should treat the sexual partner. But with yeast, there's no benefit to treating the sexual partner either. All right. A 34-year-old with no menses for 15 months. 34-year-old, gravida 2, para 1, AB1, has not had menses since her delivery 15 months ago. What's the criteria for amenorrhea, secondary amenorrhea? Previous normal menses, no menses for 3 months, irregular menses 6 months. So under either of those criteria, 15 months is certainly long enough. She has not been on oral contraceptives. She denies nipple discharge or secretions. Why is that important? Because you would wonder if you had an elevated prolactin, right? With galactorrhea. So she has no galactorrhea. General exam, unremarkable. Pelvic exam, unremarkable. Vaginal mucosa is pink and moist. What does that mean? Interpret that for me. She probably got adequate estrogen. Estrogen is not dry. Her uterus is asymmetrically, minimally enlarged. What do you think of with an enlarged uterus? An amenorrhea. Pregnancy. But doctor, there's no way I could be pregnant. Right. I mean, you've got to think of that, right? Secondary amenorrhea, the most common cause? Pregnancy. But it's non-tender and mobile, no adnexal masses. So our differential must start with pregnancy. And ovulation, estrogen deficiency, reproductive tract outflow obstruction. So let's work our way through this. How would you rule out pregnancy? Duh. Beta HCG, right? Anytime you have amenorrhea, one of the concerns would be hypothyroidism, TSH, hyperprolactinemia. So let's check these out. Urine beta-HCG, negative. TSH, normal. Prolactin, that didn't help very much, did it? However, we know she's not pregnant. So, pregnancy is ruled out, the most common cause of secondary amenorrhea. Now what do we look for? Rule out hormonal etiologies. Progesterone deficit, estrogen deficit. What do we call the diagnosis when there is progesterone deficit? Anovulation. Anovulation. So, let's work our way through this. This is a lovely, algorithm-friendly case. First thing we're going to do now, after ruling out pregnancy, is a progesterone challenge test. How do you do a progesterone challenge test? Medroxyprogesterone acetate, 10 milligrams, 5 to 7 days. See what happens. If the problem is progestin deficiency and you give progestin, you should see a positive test, which is a withdrawal bleed. Negative. This is not a problem with anovulation. If on the exam you see any scenario that says positive progesterone challenge test, what's your diagnosis? Anovulation. Every time, take it to the bank. Burn that into your mental hard disk. This is negative. So it's not a problem with inadequate progestin. Next. Must rule out the final hormonal etiology, which is estrogen deficit. Now, do you think it's estrogen deficit from the history and the exam? No, she's got a pink, moist vagina. It's unlikely that she has estrogen deficit. How would we do this? We'll give an estrogen progesterone challenge test. Here's where you give 21 days of estrogen, followed by 5 to 7 days of progestin. If your 90-year-old grandmother has a normal anatomic uterus and vagina, and you give her estrogen followed by progesterone, she'll have a withdrawal bleed. Because what we're essentially saying to the uterus is there is no hormonal excuse for not bleeding. So we do it. What happens? Negative. It's not a problem with estrogen. What's left? Estrogen deficiency is ruled out. Any anatomically normal reproductive tract would have bled by now. So, we must rule out anatomic outflow tract. How do we do that? Hysterosalpingogram. And what do we find? Complete obliteration of the uterine cavity. What do we call this? Asherman syndrome. Infection-induced adhesions following extensive DNC. How do you treat that? Hysteroscopically, you lyse the adhesions. You take your scope, you look in the uterus, you break down all the adhesions. Then you give high-dose estrogen to stimulate any endometrium which may be present. Put an IUD in to prevent the walls from adhering again, and hopefully that will treat it. This is a hysterosalpingogram, which you can't see very well, but this is a partial endometrial adhesion. But you can still see the endometrial cavity and the tubes. This is Asherman syndrome. You don't see the uterine cavity, you don't see the tubes, you don't see anything. Just adherent together. So that was what our diagnosis is. Let's summarize. On the left-hand side, we have our diagnostic tests. On the right-hand side, we have the diagnosis. And there's only 4 diagnoses. Pregnancy, anovulation, low estrogen, outflow tract obstruction. You start out with a beta-HCG. Beta-HCG is positive, pregnancy. If it's negative, we go to a progesterone challenge test. If there is a withdrawal bleed, the diagnosis is anovulation. If there is anovulation, you want to find out, are there correctable causes of anovulation, such as hypothyroidism, such as hyperprolactinemia. So get a TSH and a prolactin. That's negative. Then we go to the estrogen progesterone challenge test. If that's positive, you know it's because of low estrogen. There's only 2 explanations for low estrogen. One is no follicles in the ovary to respond to the gonadotropins. The second is the follicles are there but are not being stimulated. And you can sort that out by getting an FSH. If the problem is no follicles in the ovary to respond, what will the FSH be? High. You can take that to the bank. High FSH is ovarian follicular problem, the follicles in the ovary. If the FSH is low, it's because of hypothalamic pituitary axis problems. You're not having gonadotropins, which are stimulating. If the estrogen progesterone challenge test is negative, you get your hysterosalpingogram and look for outflow tract obstruction. And I cannot think of any question on the exam with secondary amenorrhea that you can't answer using this sequence. Any questions on secondary amenorrhea? How do you prevent it? Don't scrape too hard, and make sure that you treat infections quickly so they don't get scarring. That's how you prevent Asherman's. Okay, secondary amenorrhea. Next case, 32-year-old. Oh, this is with irregular, heavy menstrual bleeding. 32-year-old. Is she in the reproductive years? She surely is. Whenever you have a case with irregular, unpredictable bleeding, what should you think of as far as the etiology? Anovulation. You see, the initial steps in anovulation is amenorrhea. But if there is prolonged unopposed estrogen, the lining of the uterus, endometrium, will get thicker and thicker and thicker, and after it reaches a certain point, estrogen-dominant endometrium is unstable, and it starts collapsing. So your anovulation starts out with amenorrhea and then becomes irregular, unpredictable bleeding. So let's look at our case. 32-year-old, gravida 4, para 4, presents at your office complaining of irregular, heavy menstrual bleeding every 3 to 4 weeks. She underwent a tubal sterilization procedure 3 years ago. Does that have anything to do with it? Probably not. She denies a history of bleeding, disorders, easy bruising. Because we're trying to think of, could she have a coagulopathy, some sort of problem with her bleeding? Pelvic exam, no vulvar, vaginal, or cervical lesions. There's dark blood in the vaginal vault. Cervical mucus is profuse, thin, and watery. When you see thin, profuse, watery cervical discharge, what does that tell you? Estrogen effect. Now, isn't this strange? She has blood and thin, watery mucus. See, if she was having a regular progestin withdrawal, she shouldn't have estrogen effect. She's got an estrogen effect if she's bleeding. All of that goes along with your anovulation. Her vaginal mucosa is pink and moist. Uterus is asymmetric. What does that make you think of, asymmetric uterus? Leiomyomas. What would you have with an enlarged, non-pregnant, symmetric uterus? Adenomyosis. We'll talk about that in just a little bit here. So the uterus is asymmetric, minimally enlarged, but non-tender and mobile, no adnexal masses. Differential diagnosis. What could cause bleeding? Pregnancy complications, anovulation, anatomic uterine lesion. This is basically the 3 categories of what can cause irregular bleeding. It's either a pregnancy complication, hormonal problem, or an anatomic structural lesion. So, let's start with ruling out the pregnancy, beta-HCG. Okay, that's done. Amenorrhea, next step in management, beta-HCG. Irregular bleeding, next step in management, beta-HCG. Pelvic pain, particularly unilateral, beta-HCG. Pelvic mass, beta-HCG. Enlarged uterus. Okay, I made my point. Think of beta-HCG. So, pregnancy is ruled out. A common cause of abnormal menstrual bleeding. Of course, it's not menstrual bleeding. A negative beta-HCG rules out the presence of viable villi, which is what you would have with a pregnancy. History of irregular bleeding suggests anovulation. Next step. If she is anovulatory, and the problem is a lack of progestin, and you give her progestin, medroxyprogesterone acetate for 10 days, what's going to happen to that irregular bleeding? It should stop. Remember, a progesterone-dominant endometrium is stable. An estrogen-dominant endometrium is unstable. Why isn't there bleeding during pregnancy? High levels of progesterone, it stabilizes the endometrium. So if we give her progestin, 10 milligrams a day for 7 days, the bleeding should stop. And once you stop the progestin, then she should have a regular withdrawal bleed. What happens? No change. That suggests to you it's not a hormonal problem because you've given her the hormone that was missing. What's left? Pregnancy is ruled out. It doesn't look like it's anovulation. What's next? Anatomic structural lesion. Anovulation is ruled out. Now must rule out a uterine anatomic abnormality such as submucous leiomyoma or endometrial polyp. How do we do that? Look in. Hysteroscopy. What does that show? Endometrial polyps. Now you can just resect that with your hysteroscope. So, you resect them at the time of diagnosis. And that basically is your approach to abnormal vaginal bleeding in the reproductive years. The 3 diagnostic categories are pregnancy, and that's pretty easy to rule out, anatomic lesion, and the characteristic history is regular periods, bleeding in between. Or dysfunctional uterine bleeding, or another term is anovulation. And that classically is irregular, unpredictable bleeding. So you've got the 3. The other thing is, when she has the bleeding and she's ovulatory, what are the symptoms that she's got with the period? Cramping. Where does the cramping come? Progesterone withdrawal, which releases the prostaglandins, and it's the prostaglandins that stimulate the uterine contractions. When she has bleeding from anovulation or DUB, it's usually without pain, because there is no prostaglandin release, because there isn't the vasoconstriction and the necrosis. You remember this? You're set. Just follow the sequence that we went through on that case. Any questions on that? I like endocrinology because it's so... Maybe I'm too anal or something.
Just mention management of acute bleeding family through IV estrogens.
Okay, the question was, how do you manage or talk about stopping of acute bleeding with IV estrogen? You can do what is sometimes called a medical D&C. I mean, that's an oxymoron. You know what oxymoron is? When you have contradictory opposite terms in the same phrase, like military intelligence, honest politician. You know. Well, the problem with early years after puberty, the first 2 years are often anovulatory. And these young girls will have unopposed estrogen, which will build up the endometrium. And then it starts shutting off. And it can actually bleed to where it has almost lost the endometrium. And you're right down to the vessels. Here, instead of giving progestin, you give IV estrogen for 24 hours to rapidly proliferate that lining. Then the progestin. But yet the problem is estrogen. And it sounds almost contradictory to give estrogen when the problem is estrogen. But it's only in those cases, usually with a young adolescent girl who has bled down and she hasn't much of the endometrium which is left. Okay, next case, a 25-year-old with premenopausal pelvic mass. This is a great case, too. Nice, organized approach. 25-year-old. What's the likelihood a 25-year-old has ovarian cancer? What's the average age of ovarian cancer? In the 60s. In the 60s. So, it's unlikely that is. However, well, let's do our case. 25-year-old woman, gravida 1, pair 0, AB1, presents at your office complaining of pelvic pressure. Regular 28-day menstrual cycles. Last period was 12 days ago. Uses a diaphragm for contraception. And on exam, you find a 5-centimeter cystic mobile right adnexal mass. You're doing the exam, and you haven't ever felt one of these before. And there's a mass there. What goes through your brain? What could this be? Now, how do you know it's cystic? Kind of soft, see? It's not hard and firm. Now, if she has 28-day cycles, her last period was 12 days ago, she's in the pre-ovulatory phase, right? We'll come back to that. Differential diagnosis. Now, there are 3 organ systems in the pelvis. What are the 3 organ systems in the pelvis? Reproductive tract, urinary tract, GI tract. So anytime you have a pelvic mass, you should think of one of those. For instance, urinary tract. What could be in the pelvis from the urinary tract? A pelvic kidney. I mean, could that be? Sure, you could have a pelvic kidney. How about in the GI tract, what could you have? Diverticulosis. Reproductive tract. You could have an enlarged uterus, an enlarged ovary, you could have an enlarged tube. For instance, you could have a hydrosalpinx. Okay, first thing we're going to do, beta-HCG. Let me tell you about a case that I didn't have, but one of my partners had. And a good doctor, a fine doctor. Some of you who've been in the Step 2 course, I've told this before. This woman couldn't get pregnant. Infertility. They did a full workup, checked everything out. Couldn't find any explanation for why she wasn't able to conceive. She finally accepted that she just wasn't going to get pregnant. So about 8 months later, she came back in. He did an exam. Pelvic mass. Well, there's no way she could be pregnant because already checked that out, right? So what are you going to do with a pelvic mass? You've got to operate, right? This actually happened. The patient was taken to the operating room, made the incision, and then found it was an enlarged uterus that was just deviated off because of adhesions from endometriosis. Now, what explanation could you give that would be adequate to justify that? You know, basically what you're going to have to do is you say, how much do you want? Because really there's no excuse. Pelvic mass, reproductive years, next step in management, beta-HCG. Beta-HCG. And ultrasound. Beta-HCG, negative. So she's not pregnant. The ultrasound shows a normal uterus and left adnexa, but the right adnexa is a 5 by 5 by 6 centimeter thin-walled, fluid-filled, simple cyst. No septations, no calcifications. It looks like a balloon filled with water. Round, smooth, no septations. That's what it looks like. The Big Apple in New York. The most likely diagnosis, if she's not pregnant, is a functional ovarian cyst. Now, what's a functional ovarian cyst? In the first part of the cycle, follicular cyst. In the second part of the cycle, corpus luteum cyst. Every woman who ovulates has a functional ovarian cyst before she ovulates. The dominant follicle grows to about 3 centimeters in size. That's bigger than an inch. Now, you just get that a little bit bigger, and you got 5 centimeters. Now, what happens to these functional cysts? Leave them alone. They'll go away. See? But they will all look like a fluid-filled water balloon. That's what they'll look like. So, the management in this case is, she's not pregnant. It looks like a round fluid-filled balloon. Conservative outpatient observation. Follow-up. Maybe an ultrasound in 6 to 8 weeks. If it's gone, end of the story. If it's still there, then of course you need to wonder about something else. Now let me throw just a little hook into this. What if she was on estrogen, combination estrogen and progestin oral contraceptive pills? What's the likelihood of having a follicular cyst? See, what is the mechanism of oral contraceptives? They suppress gonadotropins. So if you should not have a follicular cyst. If you suppress LH, there's no LH surge, she shouldn't have an ovulation, and she shouldn't have a corpus luteum cyst. So this is primarily a realistic diagnosis where you've got a patient who's not on steroid contraception, because steroid contraceptives should suppress functional masses. So basically what we're looking at is pregnancy is the most common of all pelvic masses in the reproductive years. Numero uno. Numero dos. Simple cyst by ultrasound, physiologic, follicular cyst, corpus luteum cyst. Now, if you have a complex mass by ultrasound, such as partially solid, partially cystic, calcifications, septations, the most common in the young woman is going to be teratoma. That needs to come out because they can become malignant. So our diagnostic tests are beta-HCG and ultrasound. And that should take you through a premenopausal pelvic mass. So here's our follicular or corpus luteum cyst. We should mention this. Even if it is a functional cyst, if it gets large enough and if it is mobile, what could happen? Twist. It twists. What runs through this pedicle here? The vein, the artery. Which one's going to get shut off first? The vein. And there's going to be fluid, blood pumping in through the artery, becomes hyperemic, and as it swells, it's going to cut off even more, and then you're going to get necrosis. Now, when a person gets pain in the heart because of ischemia of the heart, what do we call that? A heart attack. This is an ovarian attack. And you need to get in pronto. If a patient comes in, has a unilateral pelvic mass, sudden onset of intense excruciating pain, your diagnosis is torsed ovary, and you need to get in there quick. Now sometimes it can twist and untwist, twist and untwist, and you can have a history of pain that kind of comes and goes. But ischemic pain is very, very painful. All right, any questions on premenopausal pelvic mass? Now, for instance, a cancer will not tors, because cancers are usually fixed. They're not mobile. See, when they're mobile, that's when you get into the trouble. Okay, question.
How much time did you have for twisting?
How much time before you get necrosis? If it's complete, half an hour. I mean, it doesn't take long. Doesn't take long. Well, if you have an acute abdomen, I mean, it can present like that. Then you get in right away. But that's kind of a judgment call. If the patient's unstable, is just writhing around. But see, one of the things you can use is the color flow Doppler, which can look at vascular flow. You should see vascular flow into the ovary. Yeah, that's an emergency. All right. Next case, premenstrual complaints. 31-year-old with premenstrual complaints. 31-year-old comes to the outpatient clinic, complains because of emotional lability, bloating, and breast tenderness. The symptoms are so severe in the week prior to her menses, she can't function. She's been eating, drinking more fluids lately, especially coffee because of fatigue, but says she recently has been under more stress at work, making her anxious, irritable, often depressed when she goes home. General and pelvic exam is unremarkable. She has diffuse minimal bilateral breast tenderness with no dominant masses. The key thing here is the symptoms are so severe prior to her menses. Differential diagnosis. She's got breast tenderness. That is a presumptive symptom of pregnancy. I think anytime you have... So I think... Anytime you have concern about pregnancy, we want to rule that out. But premenstrual syndrome strikes me as being probably number one here. And then depression. Now, what's the difference between depression and premenstrual syndrome depression? All the time. Comes and goes. And that's going to be key. We'll get a urine beta HCG, a menstrual diary. I'll show you what that looks like in just a minute. Beta HCG, negative. Menstrual diary, the symptoms occur only in the second half of the menstrual cycle. This is a menstrual diary. What you have here is the days of the cycle. 1, 2, 3, 4, and so on over here. Then you have the treatment day, the menses, and then the symptoms, whatever they happen to be. How many symptoms do you think have been described for premenstrual syndrome? 150. Do you know any disease that has 150 symptoms? My own belief is, I think we have a constellation of things that are going on here, and we just understand it so poorly that we just lump it all together. And that's why the treatments, which have been just all kinds, work for some women, but not for all. And in randomized prospective studies, you really don't see a whole lot of benefit. But look at some of these symptoms, and I'll just read down here, and I'll see if I can do it with one breath. Nervous tension, mood swings, irritability, anxiety, weight gain, swelling of extremities, breast tenderness, abdominal bloating, headache, fever, chills, increased appetite, heart pounding, fatigue, dizziness, faintness, depression, forgetfulness, crying, confusion, insomnia, cramps, muscle aches, joint aches. I mean, you can have all of these. And the key is not what the symptoms are, but their relationship to the menstrual cycle. That's really the key here. So, let's do a menstrual diary, and it is consistent with PMS. And what does that mean? There are no specific lab tests. It is a constellation of symptoms, and they are absent in the pre-ovulatory phase. They come with the post-ovulatory phase, and with the menses, they are gone. There's got to be a hormonal etiology, but it isn't entirely clear what that is. Estrogen versus progestins. Treatment. Anytime you've got lots of treatments, you have no good treatment. That's the key. So what do we have? Reassurance. I think that's reasonable. It's not in your head. You're not crazy. Eliminate coffee and caffeine, which may relieve breast pain. If the symptoms tend to be more bloating, breast tenderness, edema, then perhaps spironolactone, a potassium-sparing diuretic. Combination OCs, progestins really haven't been shown. Bromocriptine, progesterone suppositories, all sorts of things have been proposed. However, the only one shown on randomized prospective studies to have a benefit is SSRIs. Selective serotonin reuptake inhibitors. It started out with fluoxetine, but now it looks like most of them, other ones also will do that. Now, typically for depression, you need to give this for a long time in order to get a level up. It appears that if a woman has PMS, and if she can anticipate when the symptoms are coming, if she starts the SSRIs a couple of 3 days beforehand, they may be adequate to suppress. However, if you take all women with premenstrual syndrome, what percentage will benefit from SSRIs? Let me give you multiple choice. 15%, 40%, 80%. 15. It's only those who have primarily the psychic complaints, not the fluid retention. Take for instance the diagnosis called fibromyalgia. I think we're looking at the same sort of thing. A cluster of entities that we don't know how to separate, and we put them all together and we don't understand it very well. Introducing Serafem. Isn't that great? Serotonin, fem, for the feminine species, you see. Introducing Serafem, the first and only prescription medication indicated for premenstrual dysphoric disorder. See, this is more where you have the psychic concerns. She was out of control, but now, putting her back to control. And here you can see, it was nighttime. It was darkness. And now, she's more like the woman she really is. Eli Lilly, thank you very much. Fluoxetine. Any questions on PMS? Yes? The first management, you got to put SSRIs. You know, you look at all the studies, no one has shown that diuretics help everybody. You know, in randomized prospective studies, there isn't any difference between the control group and the regular one. Bromocriptine, SSRIs is really... How long? You're basically looking... Oh, you mean how long to take the medication? You start when the symptoms are going to begin, and when the symptoms are gone, then you can stop it. See, what is one of the troublesome side effects of SSRIs? Decreased libido. That doesn't go very far. Well, the idea has always been you need to give long-term to get the levels up. But it appears that for women who have PMS, it may not be necessary to take continuous. Yes? How many milligrams? I can't tell you. You start with a low dose and then work your way up to whatever. All right.
How about the pain management? SSRI also take care of pain?
SSRIs are not for pain, primarily.
I know, but for this one, there's so many pain to us. Do we need to work on that?
You see, then you may need to go with some of the NSAIDs. You know, NSAIDs may be helpful for some. The diuretics may be helpful for some. You know, vitamin B6, pyridoxine may be helpful. But in the randomized prospective studies, that's basically what we're looking at here. Okay, let's do one more. How's your bladders? Let's take a break. Let's take a 10-minute break. Okay, the next case is 22-year-old with yellow vaginal discharge. A 22-year-old comes to the outpatient clinic with a 1-week history of vague, mild lower abdominal pain, yellow vaginal discharge. The pain is dull in nature. Acetaminophen relieved the pain slightly. Intercourse makes it worse. Some spotting after intercourse, but denies vaginal itching. So the main thing we have is lower abdominal pain, yellow vaginal discharge, and the pain is dull. On exam, 99.1 degree temperature. Is that fever? That's not really a fever. Pulse, 84. Respiration, 16. Really vital signs are stable. General exam, unremarkable. Abdomen is soft, non-tender. Yellow vaginal discharge is seen. The mucosa is pink and moist with no lesions. Cervical mucosa is friable. Mucopurulent cervical discharge. I want you to remember that phrase. When you see mucopurulent cervical discharge, I'll show you a picture of what that looks like. That is what you expect with a gonorrhea chlamydia infection. However, no cervical motion tenderness. Now, one of the differentials here is PID. The characteristics finding on exam with PID is cervical motion tenderness. So this looks to me like she's got a cervicitis rather than a PID. We've got a cervicitis in our differential. Urethritis, I suppose, could cause some pain. Vaginitis. Cystitis. You notice all of these are itises? But just the story looks more like a cervicitis. So, We'll get a vaginal fluid microscopy, saline KOH, see if it's a vaginitis. Get a cervical smear. No clue cells, no trick, no pseudohyphae. Doesn't look like it's a vaginitis. Many PMNs. What's PMNs? Polymorphonuclears, right? So that would be consistent with a cervicitis. Bacterial cervicitis, probably gonorrhea or chlamydia. We're going to get bacterial cultures on Thea-Martin media. What's this for? That's for gonorrhea. And chlamydia zyme is for the chlamydia. Positive. Bacterial cultures for GC. Positive for chlamydia. Which is the most common, do you think, between chlamydia and bacterial, GC? Chlamydia. What do you think is the ratio? 6 to 1. The chlamydia is 5 to 6 times more common than gonorrhea. Although they often will travel together. They're friends who hold hands as you're marching up the cervix. How do we treat this? Ceftriaxone, doxycycline. The ceftriaxone is an IM dose, intramuscular. Probenecid prolongs the half-life in the bloodstream, and doxycycline. Which organism does the ceftriaxone attack? Gonorrhea. Which does the doxycycline? What's the mechanism of doxycycline? It's ribosomes. It's within the cell. Whereas, how does ceftriaxone work? Cell wall. See, and chlamydia is an obligatory intracellular organism. So that's why you need to get into the cell. And the CDC recommendations are ceftriaxone, doxycycline. Now, if you had only the chlamydia alone, what would your treatment be? Just the doxycycline. And that's far more common. Do you treat the sexual partner? Yes. Do you do specimens? Do you get cultures on the sexual partner? No. No. You just treat directly. Any questions on that? Do you notify the local public health? With GC and chlamydia, they'll go bonkers. They don't have enough people out there. But syphilis, yes. HIV, yes. Typically, the laboratory will notify the public health. But with chlamydia, no. Absolutely. If you suspect it, I would treat before. But if you're in question. Now, most patients, where we pick it up, they're not having any symptoms. And you just do a routine culture. In that case, you would treat once you got the culture back, but she has symptoms when she comes in. Okay, the CDC says that for chlamydia, you don't need to reculture. If you give because the treatment is effective enough. But with gonorrhea, I think I would probably reculture. Question? Azithromycin will be helpful. You could do that.
Also good to have counseling, like safe sex and hepatitis B.
That's right. They do ask all that. If they have one sexually transmitted disease, you need to think of the other ones. What are all the sexually transmitted diseases that are most common here in this country? The most common overall is HPV. That's the most common overall, the most common viral. The most common bacterial is chlamydia. Actually, the number 2 is trichomoniasis. And that's the most common parasitic. The third one is chlamydia. And that's the most common bacterial. And then you have gonorrhea. You have herpes, which is probably best diagnosed with a culture. Hepatitis B is the only sexually transmitted disease which is preventable with immunization. That is worth keeping in mind. The CDC recommends all adolescents get immunized against hepatitis B. And then, of course, HIV. Those are the most common STDs that we have in this country. Syphilis. Okay, next case, an 18-year-old with bilateral lower abdominal pain. 18-year-old, gravitas 0. Gravitas 0. Never been pregnant, and there's a good chance she never will be pregnant. Comes to the emergency department with lower abdominal pain for 5 days, fever for the past 24 hours, diarrhea, anorexia, sexually active, multiple partners. She's setting herself up for PID. Last period was a week ago. What is the relationship between the onset of PID and menses? Typically, it's postmenstrual. You see, at the time of menses, the cervical mucus barrier is broken down, and that's when you can have the ascending infection that takes place. It's very common. Irregularly uses a diaphragm for contraception. Exam, temperature, 102.4. That's a high fever. Pulse 100, respiration 16, blood pressure okay. Generalized bilateral lower quadrant tenderness. If you have unilateral tenderness, what do you think of? Ectopic. Bilateral, PID. Pelvic exam, mucopurulent cervical discharge, cervical motion tenderness. The CDC criteria, Center for Disease Control criteria for PID, it is bilateral lower abdominal pelvic pain, which she's got. Mucopurulent cervical discharge, which she's got. Cervical motion tenderness, which she's got. Elevated SED rate, elevated white count. Now, we don't have that yet, but we're going to get that. She screams PID. PID. Now, there's a lot of causes of pelvic pain. We've talked about some of these. PID, a ruptured ovarian cyst, ectopic pregnancy, appendicitis, endometriosis, Crohn's disease, which would have association with fever. PID, appendicitis. Does Crohn's cause fever? Plus minus. But do you have cervical motion tenderness with appendicitis? No, this sounds much more like PID. Diagnostic plan. Let's rule out ectopic with a beta-HCG. CBC, let's see what her white count is. How about her sedimentation rate? We'll get cervical cultures, syphilis serology, beta-HCG, negative. You can virtually rule out ectopic with a negative beta-HCG, a urine beta-HCG. CBC, hemoglobin 13, hematocrit 38, white count. That's high. SED rate, markedly elevated. Cervical cultures, we got those. We don't have those back. Syphilis serology, non-reactive. What's our working diagnosis? PID. That is kind of a generic term, PID. A better term is acute salpingo-oophouritis. Because what it is, it's upper tract disease. It's not just pelvic disease. It's upper tract disease. In the Scandinavian countries, they will often make the diagnosis by doing a laparoscopy and looking for erythematous, swollen tubes. We don't pay we pay almost 70. In those countries, they pay 70% of their income as income tax. So they've got lots of money for health care. Here, we don't want to do that. So it is made clinically. So you don't make a diagnosis based on laparoscopy. You make it clinically on the things that I said. Bilateral lower abdominal pelvic pain, cervical motion tenderness, mucopurulent cervical discharge, elevated SED rate, elevated white count. And she's got it. Okay, the cultures. Positive. So we have our diagnosis. The question now is management. The question is it inpatient or outpatient management? Okay. In her case, it's got to be inpatient management. What antibiotics are we going to use? The same ones as for outpatient. We're going to use cephalosporin, and we're going to use doxycycline or tetracycline, and we're going to go big time. You want to get high levels, intravenous treatment. Let me show you some pictures. See, this is your classic PID. It starts out with a cervicitis. The organism goes up into the uterus, but interestingly enough, it does not cause an endometritis. But it goes up into the tube and into around the ovary and sets up and causes acute salpingo-oophoritis. Now that can go a number of ways. If it isn't treated appropriately, you end up with a chronic PID. Chronic PID is basically scar tissue. No active infection, but scar tissue. Or it could get worse, tubal-ovarian abscess. See, so you could start out with a cervicitis, which then goes to acute salpingo-oophoritis. If it's treated adequately, this is what we would like to do, is that you have healing without adhesions. But if it goes the other way, you could either have healing, but with scar tissue, or tubal-ovarian abscess. So this is what we want to try to prevent. Outpatient criteria, you have a certain diagnosis, no systemic infection, no pelvic abscess. How do you know if there's a systemic infection? Fever, abdominal rebound, guarding. See, if it's salpingo-oophoritis, it is only the tube and the ovary. The peritoneum should not be involved. We already talked about those. For inpatient, if you're not sure, maybe she has an appendicitis, we're going to bring her in. Outpatient treatment failure, you tried, it didn't work. IUD in place. We want to get good levels of tissue antibiotics before we remove the IUD. Any evidence of abscess on ultrasound, pelvic exam, on CT. High fever, it used to be a gravida 0, para 0. Who is at highest risk for PID? What demographic age group? The teeny boppers, less than 20. One episode of inadequately or inappropriately treated PID, 15% infertility. 2 episodes, 30%. 3 episodes, 50%. And where is that from? Adhesions, tubal adhesions. And it's these young women. By the time you get to 30, the rate just drops dramatically. This is your mucopurulent cervical discharge. I call this a frozen waterfall. Now, if this was mid-cycle estrogen dominant, it would be thin and watery. But you can see it just looks pus. That's what it is. It's thick and pussy. Now, here is your chronic PID. A little bit bleached out, but how do you treat adhesions? You snip them? Can you imagine starting to snip here? What's going to happen? Just reform. See, this patient is going to have bilateral tenderness, abdominal tenderness, cervical motion tenderness, but she will not have the mucopurulent cervical discharge. She will not have the elevated white count. She won't have the elevated SED rate because there's no active infection. There's no point giving antibiotics. If she's got chronic pain, you may end up doing a pelvic clean-out. TAH, BSO, bilateral salpingo-oophorectomy on a young woman. Not good. Okay, questions on that? Yes? No, gonorrhea. No, it should be 14 days for both. For inpatient and outpatient. Does it say 7 days? Then it should be 14 days. The CDC recommendations are 14 days. The treatment for chronic PID is, if it's pain, mild analgesics. If it is infertility, then you do some lysis of adhesions, but it's very disappointing. Very disappointing, yes. Okay, pregnancy and PID. It doesn't happen. See, why doesn't it happen? Because PID starts out with a cervicitis. Let me put it this way, it is very rare. Because it starts out with a cervicitis and has to ascend to the tube. It's blocked by the placenta and the gestational sac and that. So unless it's early in pregnancy, you won't see that. At least I can tell you in 25 years, I've not seen a case. so it's rare. Okay. Okay, for tubal ovarian abscess, this is big time. See, the normal treatment for an abscess is drainage. This is not your typical pus pocket. This is an inflammatory mass which involves the uterus, the omentum, the tube, the ovary, the bowel. And these will often respond to high-dose antibiotics. And since these are probably going to be with secondary invaders like anaerobes, instead of going with the cephalosporin and the doxycycline, we will use the gentamicin and the clindamycin, or gentamicin and metronidazole. And if you don't see a response within 24 to 48 hours, if she doesn't get better, then you would operate. And you would either do a percutaneous drainage through the cul-de-sac, or you got to remove it. Yeah. Do you order CT? Oh, if you do an ultrasound and it shows it, then you don't need to do a CT. Which is more cost-effective, you think, ultrasound or CT? Ultrasound, I think, would be a better one. Yeah. Okay. Next case is 33-year-old with HGSIL. What is HGSIL? High-grade squamous intraepithelial lesion on a pap smear. 33-year-old underwent routine pap smear a week ago. Exam, unremarkable. Pelvic exam, unremarkable. Cervix was reddish in color, not friable, no lesions. Comes back, and the pap smear shows high-grade SIL. High-grade SIL is a cytological diagnosis. It's based upon cytology, not histology. So looking at the cellular characteristics. And this shows the pap smear classification under the Bethesda system. You have normal, you have ascus. What's ascus? Atypical squamous cells of, I don't know what they mean. I don't know what it means. Nobody really knows. Low-grade SIL, high-grade SIL, and cancer. And you can see the difference in the nuclei. Look at with the normal, the small pycnotic nuclei, you can see how huge these are. Now, our concern is that the cytology may be low-grade SIL, and that usually represents, when you do your biopsy, human papillomavirus or mild dysplasia or CIN1. The high-grade SIL, moderate dysplasia, severe dysplasia, carcinoma in situ. And this could be on CIN2 or CIN3. And if it says cancer, the importance is it minimally invasive cancer, microinvasive, or frankly invasive? And I'll show you what that is in just a minute. So, the cytology is a screening test. Our differential diagnosis. She gets the HGSIL. Could it be a false positive? Or is it, in fact, a neoplastic lesion? What is the likelihood of having a false negative pap smear? Let me give you a multiple choice. 1%, 5%, 20%, 50%. 20%. Did you know that? 20% of the time when there is a lesion, there's actually something there and you missed it. Now, what is the likelihood of a false positive? If you see that kind of ugly cells on the pap smear, you better find out where they came from. So I think false positive is very low. This is more likely a lesion which we need to look at. What's our next step in management? Thank you. Colposcopy is a management. You put acetic acid on the cervix. It enhances the epithelial features. And if you find the abnormal areas, you're going to biopsy them. And what do you look for on the epithelium? Mosaicism, punctation, white epithelium, abnormal vessels. Those are the four things that you look for. And you do an exocervical biopsy. When you look with a colposcope, you see mosaicism between 1 and 5 o'clock of the ectocervix. And it goes into the endocervical canal. That's not good. How are you going to get into the endocervical canal? The entire transformation zone is not visualized. So we clearly have an abnormal pap smear, but it's inadequate colposcopic evaluation. What you like to see is the entire transformation zone, and we couldn't see it. So what we need to do is exocervical biopsy and what's ECC? Endocervical curettage. Let's see what it shows. Moderate dysplasia. And that's not too bad, is it? It's not good. What is the normal, what's the word I'm looking for here? What would you expect to happen when you have dysplasia of the cervix? Does it always progress to cancer? What happens? Does it go away? Does it just stay there and sit? This is your endocervical curettage. This is how you do it. Scrape up and down with this little instrument here. And since there was endocervical involvement of the cervical dysplasia, the patient should receive a cervical conization. This is what happens to mild dysplasia. 65% of it goes away. How come? Because it's mild? What causes most mild dysplasia? HPV. What happens to the body as the immune system responds to the HPV? In most patients, it's gone. Certain kinds of HPV, however, do not go away. And what kinds are those? 16 and 18. Those are the most likely ones to progress. 20% will remain static and just won't go past mild dysplasia. But these ones will progress. And when you get moderate dysplasia, you're concerned, maybe this is something which is progressing. My suspicion is what we will do in the next few years, instead of doing histology, we will take biopsies. We will take HPV cultures, or at least DNA samples, and we will look for the PCR typing. And if it is a 16-18, then we will do the colposcopy and the biopsies. If it is the benign ones, we'll just watch it. I suspect that's probably what we will do in the next few years. And here's a colposcopy which is being done. What's colpo mean? Vagina. Oscopy, looking in the vagina. That's what it is. And this is what you look for. You look for the white epithelium. This here is mosaicism, and this here is punctation. Those are the areas that you biopsy. And here's the biopsies being done. You send them back. Now this is when the lesion goes into the canal. And here you can see it going into the canal. How can you find out what's going on in the canal? How do you biopsy inside this narrow? The only way you can do it is to cut it out. And what do we call that? Cone biopsy. So if the lesion goes into the canal, we do a cone biopsy. And I've in your notes have indicated what the four criteria for a cone biopsy are, and here they are. And I'm not going to go over those in any detail. If you have a problem and you want to take it out, how can you take it out? What I would put on the exam, the optimal form of management, is this, which is called LEEP, loop electrosurgical excision procedure. And it sends a hot or electrical current through the wire, and so it is like a cheese cutter. Slices it through. Local anesthesia, send it to histology. You can make sure it's actually gone. You can see it gone. This would be the treatment of choice. Another treatment would be cryotherapy, to freeze it. The problem with that is you have no specimen to send to pathology, and you don't know if it is completely gone. And on all of these, you need to do follow-up every 3 months to make sure that there is no recurrence of the disease. Any questions on the cervical dysplasia? Let me just review. If the pap smear says normal, you just repeat it. How often do you repeat the pap smear? If the patient has no risk factors, which are multiple sexual partners, early onset of sexual activity, cigarette smoking, then you would do 3 consecutive annual pap smears, which are normal, and then go to every 3 years. If she has risk factors, then you would continue annual pap smears. If the pap smear shows inflammation without atypia, you treat the inflammation, like let's say they say Candida, no need to repeat the pap smear. If the pap smear says inflammation with atypia, you treat the inflammation and then repeat the pap smear. If the pap smear says ascus, nobody really knows what to do with that. Some people say do colposcopy, others say repeat the pap smear. I would, on the exam, if it's a reliable patient, just repeat the pap smear in 3 to 6 months. If it is low-grade SIL, high-grade SIL, or cancer, then you need to do a colposcopy and directed biopsies based upon where you see the lesion. If there is the lesion going into the canal, you need to do a cone biopsy. If the transformation zone goes into the canal, but not a lesion, endocervical curettage. And treatment, as I said, LEAP would be the best, and then cryo, which is freezing it. Okay. Next case, 21-year-old with bilateral lower abdominal pain after menses. 21-year-old comes to the outpatient clinic with recurrent, severe disabling pain occurring on the first 3 days of her menses. The pain is crampy. The kind of pain, I think, is helpful to know. What does cramping pain suggest? Cramping, the smooth muscle is contracting. What causes smooth muscle to contract? Prostaglandins. Let's come back to that. The pain with ovulatory cycles is from prostaglandin release from the necrosis, from the spiral arteriolar spasm. This sounds like that. If you give prostaglandin to a patient, too high a dose, you know what you're going to find? Nausea, vomiting, diarrhea. Why do you find nausea, vomiting, diarrhea? Because the smooth muscle in the GI tract contracts too. See? So cramping pain is often associated with prostaglandins. No pain with intercourse or bowel movements. Why is that important? What kind of pelvic pathology could result in pain with menses and with bowel movements and endometriosis? Endometriosis, we'll come back to that. Periods are regular, 28 days apart, lasting 3 days. The onset of the pain was within 2 years of starting her menses at age 12. Now, this is important. When a young woman starts menses and puberty, the first couple of years are anovulatory. There is no release of prostaglandins. There's no spiral arteriolar spasm because there's no progesterone fall. And those cycles are usually painless. But when the ovulatory cycles begin and she starts to have corpus luteum producing progesterone, which then declines, that's what causes the prostaglandin release. And that's why with primary dysmenorrhea, which this sounds like, the onset of the pain is within the first 2 years of starting menarche. What will you find on the pelvic exam of a patient with primary dysmenorrhea? Normal. Normal. What's a normal pelvic exam? Uterus is small, symmetrical, freely mobile, non-tender. There's no cervical motion tenderness. There's no adnexal masses, no adnexal tenderness, and there is no recto-vaginal or uterosacral nodularity. I want you to remember that term, uterosacral ligament nodularity. That is your tip-off to endometriosis. So she has a normal exam. Differential diagnosis, primary dysmenorrhea, endometriosis, uterine polyps, chronic PID. We're thinking of all kinds of things that could cause pain. Leiomyomas, adenomyosis. But this sounds so much like primary dysmenorrhea. Not chronic PID, not endometriosis, or these other things. If the problem is prostaglandins, What can you do? Okay, we're going to do pelvic ultrasound. It shows normal pelvis. Cervical cultures are negative. The primary dysmenorrhea is excessive myometrial sensitivity to prostaglandins. We can suppress the prostaglandins with NSAIDs, medical treatment. The other thing is, if it is progesterone withdrawal, how about if we keep the progestin levels high? How can you do that? Continuous oral contraceptives. See, that would be a possibility for that. Let me show you a picture. This is from my BRS book. What happens is, patient ovulates, corpus luteum produces progesterone, no pregnancy occurs, so progesterone levels drop. That results then in increase in prostaglandins. The prostaglandins cause myometrial contractions. The myometrial contractions are so strong they cause ischemia of the uterus, which causes pain. Now, good quality contractions in labor, if you measure the strength of the contractions, 50 millimeters of mercury, they put balloons in the uterine cavities of these young women and measure the contractions. How strong they are? 150 millimeters of mercury. It's no wonder that they cause such pain. Now, if we have pain of the heart from ischemia of the heart, we call that a heart attack. If you have pain of the uterus because of ischemia of the uterus, what should you call that? It's a uterine attack. That's basically what it is. It's a uterine attack. So we want to release that. So, endometriosis, where's the most common site of endometriosis? Ovary, cul-de-sac, uterosacral ligaments. That's where you get the uterosacral ligament nodularity. How do you diagnose endometriosis? Laparoscopy. How do you diagnose chronic PID? Laparoscopy. So one of the main indications for laparoscopy is pain, pelvic pain. You can suspect, based upon the symptoms, infertility, dyschezia, pain with bowel movements, pain with intercourse, but the diagnosis is based upon laparoscopy. And you've already seen the chronic PID. Now, adenomyosis is an interesting cause of secondary dysmenorrhea. And what is adenomyosis? Endometrial glands and stroma located in the wall of the uterus, not outside the uterus. So endometriosis is glands and stroma of the endometrium which are located outside of the uterine cavity. But this is within the wall of the uterus. The only way you can really diagnose this accurately is by removing the uterus and looking at it. And then, of course, leiomyomas. Okay, any questions on dysmenorrhea? This is a common complaint, primary dysmenorrhea. And I've seen surgeons who have operated on patients. This is a medical management, not a surgical management. Yes, sir. Give what? For this? Okay, do you give oral contraceptives to young women with this? I would first go with NSAIDs. I mean, the problem is prostaglandin withdrawal. And, prostaglandin release. And if you can suppress that. But if that doesn't work, I wouldn't hesitate. But she really doesn't need the estrogen. It's the progesterone which she needs. Okay. All right. Next case. 20-year-old with right breast lump for 3 months. 20-year-old college student comes to the outpatient clinic after noticing a painless right breast lump over the last 3 months. A 20-year-old. What's the likelihood of a 20-year-old having breast cancer? Not very high. Her grandmother died of breast cancer. No other family history. Exam 3 centimeters, freely mobile, round, rubbery. I want you to remember that. Rubbery, non-tender, right breast mass. Left breast is normal. External appearance of both breasts is normal. Pelvic exam is unremarkable. A painless, mobile, round, rubbery pelvic mass, breast mass in a young woman is most likely a fibroadenoma. That is the most likely diagnosis. Now, fibrocystic disease, breast cancer, fibrocystic disease. Actually, I don't like the term fibrocystic disease. The newer term is fibrocystic changes, because it occurs in 50% of women. Anything which occurs in 50% of women is probably not a disease. Changes. That would be unlikely. This is more diffuse. Breast cancer, unlikely. The fibroadenoma would be the way to go. Diagnostic plan, mammography, ultrasound. Some would even question mammography. What is the difference in what the mammography looks at and ultrasound looks at? The benefit of ultrasound is to look for fluid versus solid, cystic versus solid, whereas the mammography looks at calcifications and other changes of density. So they really are complementary. Mammography showed a 2.5 centimeter right breast mass consistent with fibroadenoma, and the ultrasound also showed something that looks like a fibroadenoma. Now, what are you going to do with this? On this right breast fibroadenoma. This is somewhat controversial, one would say. In the past, a solid breast mass was an indication for open breast biopsy. And I think a reasonable diagnostic plan would be an excisional biopsy. However, other surgeons, have you had surgery yet? What do they say to do? Of course. Of course. I mean, a chance to cut, a chance to cure. I mean, that's what a surgeon would say. There are many who would say, and even surgeons, if it's in a young woman, let's just watch it. Others will look at the size of the lesion, and if it's small, watch it. If it's large, take it out. But I think it's reasonable to take it out. If it is benign, just reassure the patient. The decreased caffeine is really more for fibrocystic changes. Now, there's a good one in terms of treatment. What is the treatment for fibrocystic changes? Well, if there's a dominant mass, you will do a fine needle aspiration. You know how many treatments there are for fibrocystic disease? This long. Whenever you have this many treatments, it means none of them are very good. Bromocriptine, decreased caffeine. Okay. Any questions on that? Basically, if you've got a mass in the breast, fine needle aspiration. If it goes away, mammography is normal, that's the end of it. If you have a bloody nipple discharge, if you have a mass that doesn't go away after aspiration, if you have a solid mass, excise it.
So you would get the FNA or just you, as you said?
See, the FNA really is for a cystic mass. Now, there are these the kind of needle biopsies. And that is helpful if it's benign like this. Because if it's benign and it looks fibroadenoma, you really don't need to take the whole thing out. Some of the newer treatments are, believe it or not, cryotherapy. They actually freeze it with a probe which is put in. But if the core needle aspiration is positive, then you need to take it out anyway. Yes, at the back. Okay, you're talking about the fine needle aspiration, and do you?
Which one do you do first?
Which do you do first, the mammography?
Ultrasound, what is the step? In the 20 step.
What do the surgeons say?
FNA. No, in the 20
I think most surgeons would say, if you're going to get the mammography, get it before you do the aspiration. And I think the reason for that is that if you get bleeding, that it could give you a false reading on there. But that's a kind of controversial one. The only reason to do the ultrasound is if you don't know if it's cystic or whether it's solid.
But to be told that
years old, you don't see well with the mammography.
If she's 20 years old, you won't see much in the tissue? Whatever the surgeon says is fine with me. Okay. Next topic is 58-year-old woman with involuntary urine loss. Oh, what did the surgeon tell you as far as the frequency of mammography? Did not say. They had an expert panel that convened a consensus conference from the National Institutes of Health. You know what they came out with? They can't agree. If there's risk factors, mammography before age 35. No risk factors, a baseline mammography between 35 and 40. Every 1 to 2 years between 40 and 50. Annually after age 50. I think that's a pretty agreed on guidelines. Okay, 58-year-old with involuntary urine loss. Did you know the annual direct cost of urinary incontinence in the U.S. is equal to, who's the guy who owns Microsoft? Bill Gates, his fortune. $16 billion a year. Let it flow, is that what you said? That's a good pun. New Depend protective underwear. Confidence never looked so good. I suspect most women with urinary incontinence don't look quite like this lady here does. Okay, 58-year-old, gravida 3, para 3, comes to the outpatient clinic with involuntary loss of urine. Symptoms began 4 years ago after she experienced menopause. What's the average age of menopause? 51, so she would be 54. That's right. What would be the range of age for menopause? 40 to 60. Before 40 would be premature menopause. Okay. She denies burning on urination. So that would help you. Perhaps it's not an infection. She denies loss of urine at night. We'll come back to that. The only incontinence where there is no loss of urine at night is stress incontinence. All the other ones, you have loss of urine at night. The urine is lost in small spurts when she coughs and sneezes. It's not a large dump of urine. What does that sound like? Stress incontinence. Pelvic exam, protrusion of the upper anterior vaginal wall to the level of the introitus. It sounds like there may be some pelvic relaxation. So our differential diagnosis: irritative incontinence, genuine stress incontinence, hypertonic urge incontinence, hypotonic overflow incontinence, and fistula or bypass incontinence. Now this is basically your 5 and your differential. It's most likely the one that we're thinking of is genuine stress incontinence. Our diagnostic plan. What would be your cheapest test to rule out these 5? Urinalysis. Basically what we're looking at is irritative incontinence. What are some things that can cause irritation of the bladder and then it wants to contract? Infection, tumor, foreign body. What kind of medication would cause that? I can't think of any medication. But tumor, foreign body, or I suppose stones would cause it. Now, what would you find on urinalysis if you had an infection? White cells, bacteria. What would you find with a tumor? Red cells, right? Microscopic hematuria is your finding with... What would you find with a foreign body? Red cells. See, if you have a urinalysis that shows no white cells, no red cells, no bacteria, you basically ruled out irritative incontinence. A urine culture. Q-tip test. Let's talk about that. And cystometric studies. Well, the urinalysis, no red cells, no white cells, no bacteria. So we pretty well ruled that out. Urine culture was negative. Now the Q-tip test. This is where the patient is laying supine. You put a lubricated cotton tip applicator in the urethra and then have her increase intra-abdominal pressure. If there's loss of support of the bladder, as the bladder goes down, what will happen to the Q-tip? Goes up. If you have an increase in angle of more than 30 to 45 degrees, you've got a positive Q-tip test, which would suggest that there is mobility of the proximal urethra, and that is positive. Now, what are cystometric studies? This is where you take the patient, you have her empty as much urine as you can, then do a residual volume, how much is left. You leave the catheter in, and you start to infuse saline into the bladder. And as the saline goes in, you're pouring it into this tube, and you can see the level of the fluid, and you can see how high it goes. You look for involuntary contractions of the bladder, because you'll see the fluid going up and down, and then you will instruct her to tell you, when does she feel the bladder is getting full? That's called the sensation of fullness, volume. And then you will instruct her to say, when she feels like she's got to go. That's the urge to void. Okay? What are the normal values for that? These are normal. What should be a normal residual volume? Less than 50 cc's. Sensation of fullness, 250 cc's. Urge to void volume, 400. No involuntary detrusor contractions. This is normal. Our diagnosis? Genuine stress urinary incontinence. It is loss of support of the urethrovesical junction, so the proximal urethra is not an intra-abdominal structure. Here we have the pelvic wall, the pelvic floor right here. And you can see the proximal urethra is an abdominal structure. When she coughs, what happens to the intravesical pressure? Goes up. When she coughs, what happens to the urethral pressure? Goes up the same. So the differential between the two is unchanged, no loss of urine. Here we have loss of support of the proximal urethra in the bladder and neck, and it comes down. She coughs, what happens to bladder pressure? Goes up. She can't transmit the pressure to the urethra, because it's no longer an abdominal organ. So when she coughs, the intravesical pressure goes up. As soon as she stops coughing, it goes down. Does the bladder wall ever contract? No. The bladder doesn't contract. It's the pressure. Whenever the pressure goes up, it comes out. So she coughs. It comes out immediately. If she's running, if she's sneezing, if she's jumping. See? But the bladder wall never contracts. When she's sleeping at night, does any urine come out? No. See, this is the mechanism. It's important to keep that in mind. Intra-abdominal pressure is transmitted only to the bladder, but not to the urethra. Treatment. Medical therapy, Kegel exercises. You know what Kegel exercises are? I'm doing some right now. You don't even know it. You can do it when you're sitting here, waiting for the belt to go. Strengthen the pelvic diaphragm. If it's a mild case, that may be enough. If she's postmenopausal, maybe estrogen. But really, the key therapy is to elevate the urethral sphincter with the urethropexy, support suspension of the urethra, so that it is again an intra-abdominal organ. That's really the definitive treatment. Let me just run through this real quickly. It's a little table that looks at how do you approach this. We've already talked about this. Number one, it is helpful to get a voiding diary. What's a voiding diary tell you? It documents urinary loss, how much, when did it occur, what activity was she doing, what were the symptoms. At nighttime, only coughing and sneezing, when she was asleep. Okay, urinalysis and culture. That's going to be your screening test for irritative incontinence, white cells, positive red cells, bacteria. You treat a UTI with antibiotics, and if you've got red cells, how do you find out what's in the bladder? Cystoscopy. Okay, so cystoscopy for a tumor foreign body. Next question. No urine lost at night. If there is no urine lost at night, there's only one diagnosis, stress incontinence. And we talked about the management, Kegel's, estrogen, or urethropexy. Now, the second most common after the stress is involuntary bladder contractions. There's only one incontinence that has involuntary bladder contractions. What's that? That's your urge incontinence, your hypertonic bladder. You've heard about the irritable bowel syndrome? This is irritable bladder syndrome. This patient has 100 cc's in the bladder, and she feels like she needs to go. See, normally when you're sitting here and your bladder's getting full, and the bladder says time to go, and you talk to your bladder quietly and say, can you just wait a couple of minutes? And what does your bladder say?
No. Okay.
Okay, no problem. And the pressure goes down. But with this person here, she says, can you wait? What does the bladder say?
No.
Too bad. So sad. Wets herself all over. See? Now, this is not a surgical management. How can you suppress the contractions of the bladder? What autonomic nervous system does that? The cholinergic. We use anticholinergics. Is there a high residual volume, 500 cc's? You could have an overflow incontinence, a hypotonic bladder. This is from multiple sclerosis. It could be from medications, a variety of reasons. But this is not a surgical treatment either. Either self-catheterization, if it's a non-fixable neurological problem, or cholinergics, or alpha-adrenergic blockers. And the last one is if there's continuous leakage because of a fistula. Now, what's the history of a patient who has a fistula? Pelvic radiation for, let's say, cervical cancer, or radical pelvic surgery for either a tumor of the rectosigmoid or of the cervix. And this, you put a tampon in the vagina and then inject indigo carmine dye, and if there's a vesicovaginal fistula, the tampon turns blue. And you fix that with surgery. All right. Shall we take our break? Empty your bladders, but not all at once.